Hello, welcome. Rick Bukata, time for Rick's Rant. I have the honor of having two extraordinary guests this month who are going to give us two different perspectives on the workforce issue. I promise you I wasn't going to talk about the workforce issue again because I was getting a little beaten up by various people writing into EMRA, but we are going to talk about it some more. I think there's a couple of other guests down the road we'd like to get to, but let me tell you about today's guests. Gillian Schmitz is the new president of ACEP. I've known Gillian for about 4 or 5 years when she came to a conference of ours in Vail, and it was very clear then that this was a very, very special person. And Gillian, I've been a member of ACEP for about 40 years, and I've known a lot of the ACEP presidents personally, and I think we are extraordinarily fortunate that to have you as our president this year. We are facing what I believe to be a pretty existential crisis in emergency medicine. So thanks so much for coming on board.
Thank you so much, Rick, for having me. It's a pleasure to be here today.
Our other guest is Angela Kai, who is the president of EMRA. So I'm going to ask the two of them to give their point of view on what's going on workforce-wise and what they think are possible scenarios where the workforce issue can be addressed. So Angela, let me ask you to go first. What do the residents think about what's going on?
Thanks, Rick, for having us on. I really appreciate bringing the resident perspective into this, as I think of all of the segments of emergency physicians, this is going to affect us the most, since this is kind of the future that we're looking into. I would say the first thing that residents feel about it, I'll just quote Dr. Sontag before me, who is EMRA president, is that it really sucks. And we have a lot of anxiety about it. But at the same time, I think our specialty is amazing. And I think if we can come together on different solutions and, these workforce issues are things that we'll see if we do nothing, but we're definitely not going to do nothing. And so EMRA's committed to making sure that any solutions that we explore keep the resident future in mind, since we're going to be the ones that are going to be staffing the ERs.
Do you have any specifics with regard to what EMRA may be doing in the future to address this issue?
Sure. So we've been doing a lot of listening to our members through a couple of town halls, and our new president-elect, Dr. Abby Smiley, has been implementing some great polling through our WhatsApp newsletter, which goes to all of our resident and medical student and alumni members. So I think we're going to work on trying to do that two-way communication and engagement to make sure that we're staying on track and keeping in touch with our members. But most importantly, EMRA is all about having the resident voice at the tables that matter. And so we're working really closely with ACEP, who's, I'm sure Gillian will talk more about this, about the different task forces that have been assembled to try to really examine what are the right solutions that we should go for. And for example, just as one, going to the RRC and talking about how can we raise the quality of standards for residency education. There have been a lot of really good ideas, but we need to be really intentional about which recommendations we make. So at those types of work groups, we want to make sure that we have a resident at that table, making sure that that voice is represented. And we also want to come forward in a multi-organizational way so that our recommendations are coming from the unified specialty.
Gillian, who are the people at the table?
Yes, that's a great question. So ACEP worked with pretty much every national EM organization. And while a lot of the discussion has been on, quote, ACEP's effort, I think it would be remiss not to mention everybody else who's been involved in this discussion. So ACOEP, AACEM, EMRA, SAEM, EMRA, CORD, RAMS. So we certainly have the resident voice. And recently, AAEM has also expressed interest in working with us on the residency standards. So this is the whole house of medicine. This is every single EM organization working together. And this is what I think is such a unique part of our history. And for those of you who don't know me, I've been involved with resident education pretty much my whole career. I'm a recovering associate program director and medical student clerkship director. So residency education standards are very core to what I am very interested in personally. And I'm a member of pretty much all of these organizations. So it was important to me to bring everyone together and that we have a unified voice in how we attack this problem that really impacts all of us.
This problem has a supply side and a demand side. And although the demand may be expected to go up over this period of years that we're talking about, even though it's not probably there now. And maybe some people have suggested it's not going to get back where it was. Well, I think over time it certainly will, but maybe not in the next couple of years. So the idea here is you're working kind of on the supply side, and that's probably the only place we really can effectively work. When we're talking about specifically emergency medicine, but we'll talk about expanding what emergency physicians can do in terms of the demand side a little bit later. So supply side is basically about fundamentally decreasing the number of doctors that are produced through the residencies. Would that be a fair statement?
So I think we're looking at actually both the supply and the demand side. And it's interesting who you talk to think where we have the most wiggle room to impact that change. But I honestly think we can do both. So on the supply side, there are a couple of different ways that ACEP is looking at this. One is, as Angela mentioned, we're working with all of the EM organizations to raise the bar on standards. But the second part is also looking at where that growth is coming from. And I think a lot of people didn't necessarily realize this. The number of new emergency medicine programs is not helping. We certainly have seen an increase since 2015. But twice the impact in growth is actually coming from programs that already existed, expanding their complement. So instead of having 6 residents per year, they moved to 8 to 10 to 12. And that's actually a much bigger factor in driving growth than the number of new programs. But both of those taken into account is changing how many we're graduating every year. And so I think it's important that we address both of those issues from the supply side. On the demand side, there's also things that we're looking to increase the job market and looking at things in different areas. Certainly right now we have a geographical distribution problem of how do we match physicians, both young physicians and people later in their career where the job markets are, and how do we expand demand for our services outside the 4 walls of a hospital and looking at where else we can continue to evolve and adapt. So ACEP is really looking at both of those components.
One of the core organizations involved in this supply side is the RRC. Have you had much support from the RRC with regards to raising the bar of residency standards?
The RRC has been tremendously helpful in defining for years what the standards should be for emergency medicine. They obviously are not allowed to participate in any discussions regarding workforce, but they are very interested in looking at the standards and how do we redefine those to best prepare our residents for the future. And so every 10 years, the RRC does a deep dive, if you will, into a specialty. And it just so happens that emergency medicine is up for review in 2022. So this was actually a good time for us to go back and look at the structural framework of what is required for residency, and can we make some recommendations that we would pass on to them to look at and to consider when they make their recommendations to the larger ACGME board. But ultimately, it will be up to the ACGME board, not the RRC, not ACEP, not any other organization, as to what of those implementations are actually, go into effect. But we're having really great conversations amongst really all the EM specialties. And with the task forces we have right now, I will say at this point, we've not taken them back to our individual boards. But we're looking beyond just procedures. We're looking at scholarly activity. We're discussing faculty requirements. What percentage of our faculty should be fellowship trained? We're looking at facility requirements, at patient volumes of their, trauma center designations. What kind of facility requirements should be in place for residencies? We're looking at rotations and core requirements as our specialty changes, things like telemedicine and rural medicine. How do we make sure our residents are best prepared for that practice in the future? And we're looking at the critical care requirements and also the definition of what is a medical resuscitation? What is a pediatric resuscitation? How do we define those ages, those types of diagnostic and disease processes that all emergency medicine residents should be exposed to and have that access to? And then regarding the really impact of where this growth is coming from, one of the proud things that I'm really excited that ACEP is doing is reaching out to many of the hospitals and health systems who have been investing in GME and resident education to make sure they're aware of our data. So one of the largest for-profit hospital systems in the country is HCA. They've started 16 emergency medicine residencies in the last several years. So ACEP has the ability to actually meet with them. And we had a meeting about a month ago, and we're meeting with them again in 3 weeks to have a frank and somewhat difficult conversation about growth and where they are expanding and why. And I will say they were very skeptical of our data when we first presented the information about a surplus, because up until now, all the data said exactly the opposite, right? That we had a deficit. So showing them our numbers, they didn't quite get it until they actually referenced the AAMC data, which said for all physicians, there is likely to be a deficit. And we said, that's right. But if you flip to page 37, where they break it out by specialty, emergency medicine is also predicted to have about a 10,000 physician surplus. And you could see sort of the light bulb go on, and they were like, oh, and they say they want to be part of the solution. But this is where we start having really putting pressure on those systems that are starting residencies to ensure they have the latest data and to look at when and why and where they're starting programs to make sure that they meet those the bar that we're trying to set.
So it sounds like you're going to make a list of suggestions to the RRC that they consider, I would think. And yeah, you are talking about tough conversations with companies like HCA for sure. I
could add something to
Angela.
the RRC point. I think it's really important to understand that ACEP and EMRA have good lines of communication with the RRC, and we all certainly recognize that now is a natural and appropriate time to reconsider the standards. But we also have to understand that they are not a workforce organization, and they cannot restrict the workforce. And we can't just write them a letter and tell them to stop approving new residencies. The ACGME's mission, and I think this is really important to understand, is to protect the public. And they feel they do that by accrediting programs to say that they are safe for training. And so I think it's just really important to understand sort of the organizational context and also the legalities of the things that the ACGME can do. And we're committed to making sure that any recommendations that we make are have the support of the entire specialty, and also are focused on quality of standards, not based on their rationale of just picking a number of standards to try to restrict programs to the number that we want. It has to be focused on education and quality, and not about just hitting a certain target number of residency spots.
Yeah, absolutely. I was. It was clear to me that the RRC's job was not to control the spigot at all, and that in fact they just approved all of these residencies that are not university based and with the standards that are currently in place. So I would think that the standard changes are going to be on a go forward basis, and if they're going to be meeting and doing a deep dive in 2022, that I would think there would be some lag in terms of implementation, et cetera. So there's going to be a number of years that go by that may affect how this all comes about. And yes, I would think that you would need some very data-driven recommendations, and suggesting how many intubations somebody needs to do is a hard place to get data, I would think.
Actually, with the number of intubations, there is some pretty robust data because anesthesia has done a number of things in the literature that look at you probably need closer to 70 to 75 intubations to maintain just basic competency, not even getting into proficiency, where our numbers are currently 35 and a third of them can be done on a mannequin. There's less data on other things like arterial lines or lumbar punctures. And so we've gone through systematically through almost every procedure in emergency medicine and tried to see what evidence and data does exist to show competency. And in some cases we have it, in some cases we don't. And that's where we're trying to get more information. We're also going to be potentially adding new procedures with, regional field blocks and ultrasound guided peripheral IVs, things that I didn't get to do in my training that we think are going to be important for defining the skills of the future.
Actually, for our upcoming courses, there's a series of lectures on pediatrics, and one of my concerns, honestly, is to how many lumbar punctures has an emergency medicine resident done, given the fact that meningitis in young kids is so rare now, that my sense is that if they had a handful, that would be remarkable over the 3 or 4 years of their training. So yes, I think that there is some issues where skills may not be there because over time they are needed less, but are still needed when they're needed. I mean, you got to be able to do a lumbar puncture in a 2-month-old. So yeah, you have some committees or task force that are. Can you go through some of those for us and tell us, who they are and what they are?
Sure. So ACEP has sort of the 5 framework approach of our 5 pillars that we're looking at these. So the first one is the one that we've been discussing with the residency standards. And as part of that, I want to get into a little bit, what we're not recommending. And I think it's important to highlight that after the Workforce Summit, when people made suggestions, those were really just ideas that were thrown out there by, again, all 10 organizations of here's some possibilities. And from there, we held a bunch of town halls to see what people wanted us to do and what they didn't want us to do. And I think a lot of that has been a little bit confused. So 2 of the things that I heard most vocally in a negative way that they didn't want ACEP or others to do, one was a mandatory 4-year training. So that has come up a lot, and just want to be very clear that ACEP and EMRA and all the other EM organizations are not suggesting or proposing that we go to all 4-year programs. So I'll just say that off the bat. There's been a number of discussions amongst all the organizations that we will define the criteria, and it will be up to the individual program of how long it takes to maintain competency and all those criteria. And that could be 3, it could be 4 years, that will be up to the ACGME, but we are not endorsing a specific timeline. There was also a second question that was brought up of, do we create standards for nurse practitioners and PAs to be able to work in an emergency department? And there was a lot of negative pushback on that as well. Some people felt it was not appropriate for ACEP or others to create standards for other specialties, just like we don't like it when the surgeons create standards for us. And so we have backed away from that for multiple reasons. The other negative, comment I heard on that was that any criteria or standards that ACEP made for a different specialty could be used potentially as leverage for independent practice. And so for those reasons, ACEP is not pursuing either of those 2 strategies that were initially brought up back in April, and those sort of died in April or May, and we've been pursuing other strategies. So the second pillar is looking at, motivating groups to look at residency growth based on patients and on resident education over profits. And that's where we are looking and doing research on who is opening residency programs and talking to the people who are starting them, i.e. HCA, Tenet, the hospitals and health systems that are building them. There's been a lot of misperception about quote unquote CMGs starting residencies, but that's not entirely accurate. If you look at who is starting residencies, you have to have a sponsoring institution. And I think it's important to point out that 0 of the current 276 residencies are sponsored by a corporate management group or a physician staffing group. They're all sponsored by hospitals and health systems. And every group that has a contract, including the independent, small democratic group that I used to moonlight at, is getting pressure to start a residency program because the hospital wants it. And people want to keep their customer happy in order to keep that contract. So this really spans all employment and ownership models, but of going to the root cause, which is meeting with the people who are making those decisions and having these, again, frank and difficult conversations about the workforce and the future and the unintended consequences they are having by really investing in GME and making sure that they can use those spots for other specialties or other geographic areas where they may be more needed, as opposed to really concentrated urban areas that already have too many emergency medicine residencies. The third is that we're looking at loan repayment and looking at rural areas. Many of you know my husband is military and paid back his time with military commitment, but not everybody wants to make that obligation. But we know now that medical students have oftentimes in excess of $250,000 in loans after their debt for medical school. So could we use some of that loan repayment if they worked in a rural hospital for 4 years? Or how do we expand residency training into rural areas to get those critical skills in critical access areas and to have that comfort in working in an environment that's pretty different than the one they may have trained in? Fourth, we're looking at scope of practice, and ACEP does believe in the physician-led team, but we are very adamantly opposed to independent practice. And so this is something we're spending a lot of time from an advocacy standpoint, showing the value and the difference in training between a physician and a PA and a nurse practitioner, and making sure that we are advocating for physician-led care in all emergency departments. And then fifth is expanding demand. And this is really looking at, again, where we can adapt our skill sets and really advocating for things like proceduralists and having extra critical care training and really the post-acute care space to look at other options. And I recognize that not all young physicians are that excited about geriatrics or urgent care. And I want to be clear, that's not the message of we're saying this is your future. And I used to think that when I was in my 20s, that I would never want to do that. But now that I'm in my mid-career, having a shift a month in urgent care is actually not such a bad thing. But we want to make options that hospitals will always be our bread and butter of what we do and where we practice. But how great if we could expand beyond that? Because we're not the first specialty who's had this challenge, right? Anesthesia had a surplus a number of years ago. And how did they handle it? They expanded the scope of what they did beyond airway and started embracing pain management. And that's now really exploded in really what their core bread and butter skills are. Well, we need our own pain management. We need to look at where else we can grow outside of hospital-based emergency departments. And I think there's a huge possibility for new delivery models and telemedicine and hybrid care of how we continue to define who we are in the future.
One of the things that I'm kind of surprised at is that ACEP hasn't gone down the path of making recommendations regarding training of PAs and NPs, because there's always a medical director in the department who's responsible for the quality of the care provided. And I do think that since these folks are providing care in conjunction with the directorship of physicians, that the physicians could say, if you're going to be a PA or NP working in the department, we expect that you have these skills or this training. And right now, a person can come right out of training and go starting in emergency department. And as you know, Gillian, we are in the process of training all the emergency physician replacements. That's what I'm accused of. By training PAs and NPs, I've had doctors say, you're training our replacements. And obviously that's not true. I think that we're not going to get rid of PAs and NPs in the ERs, likely. I know some people would like that, but I don't really personally think that's going to happen. But I do think we have a say in who works in the department, not necessarily the nurses, but these other physicians are prescribing and they're ordering tests and the like, that something that only physicians can do. So I'm kind of surprised. We would not be making recommendations regarding other specialties. The specialty they're working with is emergency medicine, which is, our turf. But I could see PAs and NPs and those organizations that represent them pushing back on our making recommendations. But if you can work in an ER as a new graduate, I think many people are concerned.
I think it's important to take that concern seriously. We are anecdotally hearing of a number of cases where people are being replaced by PAs and nurse practitioners, and certainly in other fields. There have been cases in anesthesia where they have completely gotten rid of the anesthesiologist and replaced them with CRNAs. So I think to ignore that would be a mistake. I think we have to address that, but work collaboratively with our entire specialty to define what that scope is and what adequate supervision is. And so what ACEP is proactively doing to address that is we are creating our own accreditation standards. So just like trauma centers have a level 1 or level 2, status, we're trying to do the same thing for all emergency departments. How great would it be if ACEP could really define what an emergency department is, what it should be, that you have a certain staffing level, certain patients per hour that is safe, certain physician autonomy practices to make sure that you can, eat and drink at your workspace, that you have the resources you need to do your job safely. And I think that's a way we can proactively advocate for good patient care, good collaboration between the whole team, but ensure physician-led care in every emergency department.
Yeah, I think it's really impressive that you have addressed these 5 pillars, because each one of them I think is really, really important and actually fairly discreetly unique in terms of what it's addressing. So I take it there's chairman of these task force, and that periodically you come together in some way to cross-pollinate each other.
I love the cross-pollination. So the workforce has been sort of a responsibility we created and delegated to the ACEP president-elect. So as that was my job last year, I am happy to pass the torch on to Dr. Chris King, who will be our president-elect this year. But again, we are working collaboratively with all the leaders of all of the EM organizations, particularly on that first pillar on defining what those standards are. So we've had individual work groups that have made up of members of those organizations. And we're at the point now almost where we're in our draft of taking it back to our individual boards to discuss those and vet those recommendations in more detail. And, I think there are going to be some that we largely agree on. There are going to be some that we don't have consensus on. And that's okay. I think it's great that we've been able to come to the table and have a really open, respectful discussion and really question a lot of different things of how do we improve our specialty? How do we best prepare for the future? And it's been a really wonderful part to be involved with and to bring everyone together to the table to have these important discussions to guide our future. And I really want to applaud ACEP and all the organizations for having the foresight to do this. This was a decision made back in 2017. And at the time, people thought, we are never going to have enough emergency physicians. Why are you guys doing this? This is a waste of time. This is a waste of money. But really, people saw changes to the growth of residency programs, to the increased number of PAs and NPs, and saw this could really be a problem. And we need to get ahead of this. And we can't just have observational predictive modeling. This is something we have to actually have a prospective study to look at the attrition, to really look at the growth and understand what different projections will be based on different modelings. So this is a lot of work went into this, and it took 2 or 3 years to collect that data. So it wasn't published until April of this year, but know that this work has been going on now for 3 or 4 years and was a significant investment of time and money to have the best accurate projections possible, as opposed to just kind of guessing what we thought might happen with the workforce, because we don't want to overcorrect, right? 10 years ago, we didn't have enough emergency physicians. And it's very possible that in 5 to 10 years, depending on how effective we are with these pillars and market forces, that we don't want to overcompensate and then not have enough emergency physicians again in 10 years. So we have to kind of keep looking at this and restudying it, remeasuring it, and seeing what the impact of these changes are over time. It's a very dynamic modeling process.
Well, one of the impacts I think is already apparent. I saw an article recently that said that the number of applicants to emergency medicine residencies is down about 200 applicants compared to this time last year. And I don't know what the ultimate number is going to be, but people coming into the specialty or interested in emergency medicine may say, I'm really concerned because I saw this and maybe they're going to, I had a physician who was getting out of medical school and asked me about emergency medicine versus trauma surgery. She wanted to be a trauma surgeon, but the fact of the matter is that it was then known that this report was out. Also, in 2017, U.S. Department of Labor Statistics also predicted that we would have a surplus of physicians. And in their 2020 statistics note that they thought that between now and 2030, the world would need 13,400 more emergency physicians, but they never really counted the people in the pipeline. And so the people in the pipeline far exceeded 13,000 physicians. So their excess is really similar to what ACEP's. I have no doubt that this is a study that we could rely on in terms of, at least at this time, with regards to potential excesses if we don't change anything that we're doing now. Angela, let's talk about a really, really touchy subject. Maybe you don't think it's as touchy as I do, but you mentioned before we started about the PANP issues in the department. Where does EMRA stand on that issue?
Yeah, thanks for the question. I think first, we have to say that we definitely value our NP and PA colleagues. They were brought into this specialty for a reason, to help extend the work of the physician, but we adamantly oppose independent practice. We think that patients come to the emergency room to see a doctor, and they expect that their care is going to be directed and supervised by a doctor. And so that's the standard of care that we should provide them. In terms of the concerns about doctors being replaced by NPs and PAs, like Gillian mentioned, I think that this is a concern, and it shouldn't be that way for the reasons that we mentioned. In terms of training of NPs and PAs, our membership honestly is kind of conflicted on this issue. We believe strongly that physicians should be directing the standards of who is qualified to practice in the emergency department. But perhaps, as Gillian mentioned, it doesn't make sense for us to tell them, the exact criteria they should have on their postgraduate training programs, but maybe there's other ways that physicians can make sure that who's working in the ER is qualified to do so. Maybe that's at the medical director level instead of, micromanaging their certification exams, for example. But overall, we believe that APPs should be always supervised and directed by physicians. And, NPs and PAs are not, even though legislatively they've made a lot of headway on the offensive of advocating for independent practice, we don't think that's how they're trained. I think they should be trained in a collaborative model. I think there's two interesting things I would bring up to that point. There was a case in North Carolina where a CRNA was not held liable for their decisions because the Supreme Court had previously ruled that nursing was not to be in the expertise of diagnosis or treatment. So I think, for them to assert independent practice, they have to be held liable to the same standards, and that's not currently the case. And we know that the PAEA, which is the Physician Assistant Education Association, when they polled their program directors of PAs, they don't feel that PAs are effectively trained to be independently practicing because that's not the model that they work in. So we just want to continue to assert that there's a physician-led team, that we value their contributions, but that it must be determined at the physician level.
Yeah, there is a lot of tension here because although this legislation has been opposed for decades in California, in January they received the ability to independently practice. And when you talk about independently practice, of the 23 or 24 states that now allow that, some states require that you have a reasonable amount of experience before you can do that, 5 years or more in some cases. Other states allow you to work independently the day you graduate. And it's about 50-50. So I think there are concerns. I hear them all the time from PAs that are feeling uncomfortable being in the emergency department. They want to be there, but they don't feel comfortable necessarily with the responsibility that they've had. And I think, honestly, that is the job of the medical director, to make sure that the people providing care to the patients there are able to do it. And I have a rather old-fashioned idea, which will probably be rejected out of hand. But I think when people go to the emergency department, they deserve to be seen by a physician. And even if it's a stick the head in the door and just say, I saw your x-rays and I agree with, the PA that, you won't need anything more than an X. That, I think, is viewed as an old-fashioned idea. I personally think that would be a great thing to do in the emergency department, because honestly, I think people in the emergency department may be paying concierge level prices and yet never get to see a doctor. I know of a malpractice case. A malpractice attorney took his wife to the ER with abdominal pain, and the diagnosis. It was appendicitis that was missed. She wound up with an abscess, et cetera, had a colostomy, and it was a mess. And the woman was never seen by a physician. And so to allow that to happen, I know I had a relative who had ruled out PE after a operation, go into the ED, and was never seen by a physician. And it's like, geez, I don't know that I feel, I think they did everything right, but I would have liked to have a physician kind of check in with that and know that, have that relative know that it was a team of physician and the PA that saw them. And so I think, I don't think if people want to do that, but I also think on the other extreme, you have PAs and MPs seeing patients on their own that are considered more minor cases. And at the end of the shift, the doctor signed all these charts and never saw these people. And I say, you should never put your name on a chart of a person that you've not seen. Like, what does that mean? What does it imply? So I think there's some really kind of basic things that are happening. And I think the ERs are getting more and more comfortable about letting PAs see cases, which give me the heebie-jeebies a little bit about. I do honestly support the idea that not everybody needs to be worked up completely by a physician, but I think a physician is responsible for every case in that department. And if you get into a malpractice issue, the whole issue will be lack of supervision on the part of the PA or NP, and that's why this happened. So many physicians I've been told that they don't want anything to do with the PAs or NPs. They think that that increases their risk. And frankly, their risk is increased no matter whether they choose to embrace it or not. They have the responsibility. So that's why I don't think it's unreasonable to suggest what the training would be or should be for people who are working in the ED, since we are responsible for their behavior. Gillian, any thoughts?
That's a tough one. I think our membership is split on that as well, because some people do have real concerns that we are training their replacements and they don't want to participate in that education, or that some people really feel that there are certain skills like abscess, incision and drainage, or laceration that we could delegate to PA or nurse practitioners, but they don't feel there is a role for critical care or central lines or airways with PAs and NPs. I've talked to other people who feel differently. I think, one of the most contentious parts of, we created an NP PA supervision task force a number of years ago, which included, ACEP and EMRA, but also SEMPA and AAENP, to see where we could come up with consensus. And that was one of the most difficult, I think, parts where there was never consensus, is how do you define direct supervision, indirect supervision, remote supervision, what is appropriate and what's not. And I think it is because our volumes, our acuity, our experience, and our training programs are so different between different programs, that what works in one site may not work in another. But it is an area of, I would say, fierce debate right now. And this is why, we're not necessarily recommending that ACEP come up with training standards specifically, but that we look into accreditation of emergency departments for adequate supervision. I think, as someone who's been in residency education, I am required to see every one of my patients that are seen by a resident. And that resident has a lot more experience than any PA or nurse practitioner. So why wouldn't I be required to see all of their patients as well? Or at a minimum, to know about them and to wave at them, like you said. Ironically, the people who have pushed back the most on that have been the small democratic groups who say, look, this is not feasible for me to see every patient in the emergency department. I've trained and worked with this PA for 20 years. I feel very competent with them taking care of this laceration. I don't want to have to see every patient. So there's not consensus on this yet. And I think that that's going to evolve over time, but that is a complicated one right now.
I think one way to summarize it, if you look at from the patient perspective, we want everyone working in the emergency department to be well trained and qualified to see patients. And so we want to provide that additional emergency medicine specific training for our non-physician providers, but we also don't want that to be confused as equivalency with residency training. And we also don't want any of that education to interfere with residency procedures or education. So if we can find a way to achieve all of those objectives, I think that's where we're going for, but it's difficult to say exactly how you would do it.
One of the concerns of the PAs is they see the NPs getting independent practice ability, and they are kind of left in the dust because that's not going to happen with them, because the NPs go through the nursing board of the states. They convince the nursing boards that we'll work in the rural areas and we'll help out in primary care. They get the legislature convinced, and that's what they did in California. The physicians are in charge of the PAs, and so the PAs are not going to get very much support for independent practice because they have to go through the medical board of the state of California. And so they do have some concerns about the advancing at least legal capabilities of a nurse practitioner versus where they stand in this process.
But it's important to point out that we have had states that have passed independent practice for PAs. So Maine passed that law about a year ago now. So there is legislation that allows for independent practice of different providers. And I mean, to the physician assistant's point, they have much higher qualification standards than nurse practitioners. So I think it is hard for them to see a change. And especially if someone who has lower qualifications, not as much training, not as many hours, maybe doing some of it online, getting independent practice, and then where does that leave them? So it's complicated again from many different levels of what is really required. But I think what Angela and I are saying is that we appreciate our colleagues. We believe that emergency medicine is a team sport, but we believe in a physician should really lead the care of every patient in the emergency department, because what we do is really dangerous. We see the undifferentiated patient, and you don't know what you don't know. And this is why we need to work together, but to rely on those years and the totality of our clinical training and experience to really take the best care of those patients. But I think there are ways that we can work together to address these difficult problems across the specialty.
Yeah, there's a big push in the NP world for sure to get a doctorate now, and I don't think you can get out of a NP program without getting one. I don't think, and now the PAs are developing doctorates in their practice, and so it's kind of like that even adds to the credentials of these folks, but not really, because when you look at a doctorate. One of our NPs got a doctorate. It really had nothing to do about their clinical skills whatsoever.
But what does the patient see, right? They introduce themselves as doctor. They wear white coats. Like, we have lost our role. Whereas on the opposite, I can introduce myself as a doctor 10 times and people still think I'm a nurse because I'm a woman. So there's a lot of different perceptions from the patients on who is taking care of them. And I think that is what we're really fighting for, is just transparency and who we are, what our credentials are. And not blurring the lines by using words like doctor or resident or fellow that are really intended to mean something different than what the public is necessarily really being impressioned to think what it could mean. And that's what, I think EMRA and ACEP and others have worked really hard to recapture the word resident and fellow, that this is meant to be physicians in training.
Absolutely. Well, speaking of the two of you being considered nurses, the fact that you're in leadership positions is, I think, clearly a trend. And I think that the example the two of you are setting is just going to inspire other women to, get involved. And they can see that, we have had really just a handful of women presidents, but now I think it's going to be more likely that we have more because, of the pathway that you're and helping create, Gillian and Angela. Any final words?
Just thank you for having me, and thank you to your audience for listening. Nothing is final. We are continuing to look at this and relook at this and listen to people's concerns and considerations. So please reach out to us if you have specific recommendations or ideas you would like us to focus on. We really want this to be an open dialogue to help work on the specialty together.
Can't ask for more. Angela?
For sure. I would second that about wanting this to be an open dialogue. I think both of us are very accessible. And I think I would just close on sort of a message to our medical students who you referred to before as they're looking at our specialty. We know that we're facing a lot of challenges, but emergency medicine is still an amazing specialty, and it's going to continue to evolve just like it has over the last however many years. The specialty looks different than it did before, and it will look different in 20 years, but it's still going to be an amazing place to take care of patients. And I think we're committed to making sure that it stays that way.
Thank you both for taking the time and giving us some of the things that you're doing and some of the things that you've learned. I think communicating this to the physicians who are members of EMRA, EMRA, is a really good thing to do. I think that you both convey a spirit of confidence and optimism which I think is really important to continue with. So thank you both, Gillian and Angela. That's a wrap. Thanks for listening, folks. And if you have anything that you want to say regarding this segment, wrbukata@gmail.com. I answer every one of those. And I thank you all for listening. Bye for now.